For you, doctor, you said that it doesn't survive long on hard surfaces. How about soft surfaces? Like clothing and etc.
Clothing would be the same. It's just not a hardy virus. It dries out quickly. It does not survive.
Our hospital plan to address that is to disinfect any hard surfaces, and then the things that are not cleanable, mattresses, cushions, will be disposed of.
Are these suits one-time use only?
These suits will only be used once, unless it's in a training environment. So we continue to use them to train so that we don't waste our suits. But the ones that we use in care of the patient will be one-time use.
First, thanks a lot for what you're doing here for the people who came. One policy question and a couple technical questions which can wait to whatever other questions people have. What is the policy of the Commonwealth of Virginia regarding isolation? The biggest discussion I've seen in the public news has been the reception or attitude toward the state of New York and state of New Jersey have done towards isolating someone who has come from one of those countries. In this case, I think it was discussed among the nurse who's now in Maine. What is the Commonwealth's policy in terms of isolation and quarantining, and does the hospital have one on top of that which they can exercise in a legal manner?
I can speak more to the Commonwealth policy or procedure for this. You know, there is a difference between isolation and quarantine. Isolation is where we have someone who is currently symptomatic, currently ill with Ebola, and we are trying to isolate them from the community so that way we can protect everyone else. That would be done in concert with a hospital like Augusta Health. If it's a traveler that's coming in, generally through Dulles, Loudoun County Health District up there has a plan with CDC and some of the Northern Virginia hospitals to isolate symptomatic travelers coming in from West Africa up there. With quarantine, that is looking specifically at folks that we feel have reasonably been exposed to the Ebola virus, and then restricting them or quarantining them, isolating them in a sense. Bad choice of words. In quarantining, we're trying to keep them separated from the community, even though they are asymptomatic, they are not ill. And we are trying to do that in a way that is the least restrictive way possible. So there's two points to that. One is that there has to be a reasonable exposure, and we have to do it in such a way that it's the least restrictive means. We're talking about taking away someone's right to go on their day-to-day stuff for 3 whole weeks, and that's something that has to kind of play into this. And there are a lot of resources that would need to be expended in order to maintain someone closed off from their community for 3 whole weeks, including them not being able to get to their job, food, laundry, waste, etc. All that would be the responsibility of the government agency that is putting them in quarantine, if that is in fact involuntarily. So what the Commonwealth is doing essentially is, as these people are coming in, we are screening them, and we have a low risk, some risk, and high risk category that we are assessing these travelers. If we feel that it's low risk, they will continue to be monitored by the local health district for the 21 days, which will include them taking their temperatures twice a day and us calling them once a day to check on them. But because they are low risk, the type of potential exposures are felt to be minimal. And this information can be found online through the CDC website as well as the Virginia Department of Health. The some risk category, it has been focused really heavily on healthcare workers who have been taking care of patients in West Africa, even though they've been fully donning PPE appropriately. And with those some risk healthcare workers, as long as there's no feeling that they've been directly exposed to body fluids and that they've been practicing their PPE abroad, then they will have 2 temperature checks a day as well as 2 checkups from the health department, one in person on a daily basis and the second one by phone. And all that has to be arranged and kind of laid out on day one. And we do that for the full 21 days of their supposed or potential incubation period. And if, for whatever reason, we feel that they are not able to maintain that, then there's a whole discussion that has to go up the chain well beyond the health district to VDH and central office with the health commissioner to look at whether or not we need to be more restrictive about what those individuals are doing within the community. And part of the reason for that is because of the cases that we have seen here, most of them have been healthcare workers who, reported wearing PPE while taking care of patients in West Africa, and yet have still developed symptoms of Ebola. And so that's why they kind of fit into that some risk category where we are upping our monitoring, kind of increasing the restrictions, and trying to work with them to protect the community. And then for those that are screened as high risk, they are going to be kind of managed with the Loudoun Health District up at Dallas with the CDC, where they will have more of a stringent quarantining practice and possibly involuntarily quarantined if it's felt that they were exposed to body fluids or have some sort of high-risk exposure, and they will not voluntarily follow our recommendations for being able to protect the community while we wait out their incubation period. So that's sort of what's happening at the state. We've had meetings on Friday, Monday, and Tuesday at 3 p.m. as VDH tries to adjust and work out the details of this particular procedure based on the recommendations that seem to be evolving at the CDC. The CDC recently put out on Tuesday some changes and some redefinitions that had to be worked into our procedures. And so, we have a handle on what we're looking for. We have a plan in place to communicate and to monitor anyone here locally. On a daily basis, I believe we're getting somewhere between 10 and a dozen travelers from West Africa coming into Dulles, approximately. I think we as a VDH have a line list of 60-ish people that we are currently monitoring on a daily basis. Most of that's Northern Virginia, so we haven't had any here that we're doing it yet. But our plan and our action would be the same.
And I maybe not hearing you properly, but from what you're saying, I'm under the impression that there's still an awful lot of decisions to be made higher up on how to handle these things. I guess what I'm hearing you say that there's a lot of general discussions going on, but if we all of a sudden had a case right now, we have to understand that there is not yet decisions made at a higher level on exactly what to do.
Because this is a fluid situation, there will always be discussions on a daily basis as we go through this. We do have a plan that involves assessing someone into a low, some, or high-risk category. We have the definitions for that. Based on all of those, we have a plan of action of how we are going to recommend that they restrict their movements in the population, how frequently we're going to monitor them, and then whether or not they actually need to be involuntarily quarantined, depending on their risk. That all is established and has been established for a while since this whole thing kind of started rolling out. The challenge that we have at the local health district is that every single person, every single situation is going to be unique, and there is going to be the need for public health assessment and good public health judgment on a case-by-case basis as it relates to assessing those individuals, looking at what their exposure is, how we're going to classify them, and then move forward with implementing what we have planned.
So are you
Just to
asking
clarify
specifically
that-
about a patient that we has Ebola, or somebody that is potentially has?
I was going to ask you to clarify. Mr. Falk is talking about someone without symptoms. Dr. Just was talking about someone with symptoms. So I think there's.
Well, I'm
two
asking
different-
to clarify which
you're
person
talking
you were
about.
asking.
Point of
My
clarification.
impression of that is a high chance that they are at risk.
So not diagnosed yet, but concerning risk factors.
And well, we're getting to the stage of All right, he or she's going to have to be involuntarily quarantined. All right, has the state said, yes, we will involuntarily quarantine people, or have they made that firm decision? And if they have, then have the locations where that quarantine is to take place, have those been decided? Have the details been worked out of how to get them food, how to do the various things, or is that still a talking stage?
The health commissioner is prepared to execute an involuntary quarantine order based on the risk assessment and how well that particular person is willing to work with the Virginia Department of Health. Again, because the quarantine has to be carried out in the least restrictive manner, generally those individuals will be quarantined at home, and then it involves us as a local health district working with law enforcement, social services, and schools, depending on who all is involved and what needs to be addressed. And so this is something that has been discussed not only for Ebola, but for any other particular disease of public health concern in which an isolation or quarantine issue would have to be pushed out.
One follow-up, and maybe this clarifies it all. Am I correct in hearing that there is no formal location, Loudoun County or otherwise, which is a quarantine facility? Is there an established location, quarantine facility, if we should come upon a case where someone should be quarantined? Or is it relied totally on having them restricted to their house where they live?
That question goes beyond the scope of our local health district, and I can't speak to specifically what they have documented in plans.
Okay.
You know,
All right.
that would be a question for VDH at the central office in Richmond.
That's fine.
But in terms of addressing any sort of quarantine issues, that would also depend on the particular person, whether they are a resident of Virginia, and if they are, then we would be looking at least restrictive, meaning them at their home. If they are a traveler and are not a resident of Virginia, then yes, there is a plan, the details of which I'm not privy to because of my role here at the local level. But they would have a plan in place to establish someone in a site for the quarantine period. Yes.
I'm Dr. Bird from Winchester. Dulles is up my way. I have some questions on the treatment or the staging of these people and their risks when it is based on people reporting that they've had exposure to symptomatic people. Now, we've seen some cases here that have led to problems. The doctor in New York traveled and said he was asymptomatic, in fact said he had self-quarantined himself, and the police found out by using his metro tickets and checking where he had been that that in fact was not the case. If you're going to say someone's high risk because they've had exposure in the household and direct contact, are you asking people that come over from those high-risk countries if they've had that contact? Are you asking them if they've had any exposure to dead bodies over there, or are you just asking them if they've had fever or symptoms themselves? Because the CDC itself says those high-risk people should be isolated until the disease is ruled out. And when you get down to the other risk factors, like some risk factors, again, how would any person here know if I had a stomach ache or diarrhea or a headache right now or a fever, unless you took my actual temperature for screening, and that's only one thing, in which case it's a sign. In other words, if you're going to base it on symptoms, the public out there is not going to know if they've had exposure, and you're going to classify them different and then let them go out. Now, one other thing is why it's so important is, in fact, there's 40 cases at least, on average, coming through Dulles every single day. You might be referring to the ones, the lesser amount, that are followed up, or supposedly followed up here. Ones that pass through and not followed up by a Department of Health. There's 100 to 150 a day that come into the United States. Like I say, Dulles gets about 40 of those. They step off, they get connecting flights, they're in the terminal, and they're not followed up at all. Okay, they get back on their flights. And again, they could be high risk, and by the CDC's own definition, should be isolated until the healthcare professionals can be certain that they don't have Ebola. So could you comment on how you can actually isolate these people to correct risk stratification when you don't know what their symptoms are and they're not truthful?
Well, I appreciate your clarification on the numbers, those folks that come through Bellis. The Customs and Border Patrol and the CDC have a line list of specific exposures that they will be asking beyond just symptoms. So they will be asking whether or not they were a healthcare worker, what kind of contact or what kind of work did they do as a healthcare worker? Did they participate in any sort of burial practices? Was anyone else in their home sick? Do they know if anyone else had Ebola? Did they have contact with Ebola? So they will be going through this whole screening, and if there are any flags from Customs and Border Patrol, it goes into a second tier with the CDC handling that and going more in depth with some of those questions. And then from there, it is assigned sort of a risk, high, low, or some. And then based on that, that information is then given off to the Loudoun Health District and the Virginia Department of Health for us to follow up locally. As with any disease investigation that we do, whether it's pertussis or whether it's working through a norovirus outbreak, there is an element of deception that people could give, and that obviously is being reported in the news for some of these cases, whether it's Mr. Duncan in Dallas or whether it's the physician in New York. And we have to work with what we are given. And we do the best that we can with the information that we have based on how we do our interviews and the questions that we ask. Now, if in the event that someone somehow manages to lie their way through and get into our community, that is especially why it's critical for us to establish the teamwork that we have with all of the agencies here, because 911 dispatchers have been trained to ask about these symptoms and ask about travel if they get a call of something that's suspicious. Their dispatchers are trained to call their EMS folks that are going out to give them a heads up that this may be a high-risk situation, and then call the hospital and the health department to make them aware. And so we have plans in place, and we have practice and drills and coordination in place to minimize the risk in the community if something like that gets through. So
You're also taking temperatures too. You're using thermal imaging to measure body temperature.
well, at the
Points of entry.
yes, at the points of entry, they are taking temperatures and doing the full thing. And I can't really speak to that as an authority on it because I'm not with the CDC or the Customs and Border Patrol. But to the extent possible, we are going to identify anyone that may be high, some, or low risk, and then we will be monitoring them. If for whatever reason we have someone that comes in that got through that system and yet does develop symptoms, because if they have Ebola, they will be developing some very distinct acute symptoms, and at some point will enter into the healthcare arena. And we have enough presentations, enough meetings that people are aware from the dispatch 911 centers through to the hospital, along with the health department, fire, EMS, law enforcement, that we will pick that up. And once we have that, we go through our normal public health investigations like we do, whether it's a case of meningitis or any other severe disease, where we identify the contacts, we educate them, we work with them through the situation because we understand that it's going to be a very difficult situation. We have nurses that are trained to educate, to talk with, to monitor, and to identify contacts appropriately and work through that system to do our job to protect the community.
You showed the employee with the suit on,
Yes.
standing in a bucket or a big tub.
Yes.
I presume that tub is where they stand when they're doused with bleach?
That bucket is, the tub is used after the bleach for the removal process. So the equipment is removed, it's folded down
Into that container?
into the bucket so that it can be disposed of safely.
And your buddy system, would that be on another person who may or may not have worn a suit, but what do they wear to assist?
The buddy is fully dressed in the same equipment.
So the buddy system and the person who would help the first person get undressed, they remain in that suit until they help that person get undressed?
Yes, sir.
Then who helps them get undressed?
That's their entire job. So they are the observer. They are there to watch the staff member come in, to the room prior to treating the patient to make sure that their PPE is placed appropriately and that there's no exposed skin. And if you don't pass that inspection, you don't go into the room. So there's an observation process on the way in, and then there's an observation and assistance on the way out.
Just out of curiosity, then, who helps the observer who is in that suit monitoring the individuals who are serving the patient? Who helps them get undressed?
That's a great question. The process will continue. There will always be somebody as an observer stationed at that station until the patient is no longer in the hospital, at which point that person will be decontaminated with the bleach solution. They have not been in direct contact with the patient, and the observers are expertly trained. They are our highest level of training.
Yes.
Will remove their own stuff.
Okay.
Because at some point, there is only one person left, and that's the...
I realize that. That's what I'm asking. I realize what it gets down to. Yes.
Yes, ma'am.
I've heard in the news that the incubation period could actually be up to 42 days. Is that coming anywhere from the CDC? Has anyone even mentioned that it could be longer than 21 days?
I have not seen any data that suggests that is. I have no data that says it's greater than 21 days.
I haven't seen any data. It does remain in the semen for 60, I believe it's 60 to 70 days. But otherwise, I am not aware that it's beyond 21 days.
The number 42, I believe, may be stemming from the fact that from the CDC and from the health department, when we try to declare that an outbreak is over, we are looking 2 incubation periods out from the last case and when they were last contagious. And part of that's, safety, to make sure that we haven't missed anything. If there was a case that went, unknown to us and was continuing to spread disease, within 2 incubation periods, we would have picked that up. So we do that same thing, whether it's, an outbreak of flu or norovirus or pertussis, when we were working with a school system or a nursing home, when we are kind of towards the end and we are establishing, this person may be the last case, when they are no longer contagious on day Y, then we are looking at 2 incubation periods. We are going to be calling this outbreak over on day X. And that's, I believe, where the number 42 is coming from, because we'd go 2 21-day periods for a total of 42.
You monitor the temperatures, but what if somebody doesn't develop a temperature? They develop some other symptoms. How is that caught?
For Ebola, and correct me if I'm wrong, the temperature will obviously progress, and the fact that it was called Ebola hemorrhagic fever initially, now Ebola virus disease, the vast majority of people do develop a high acute fever. And
But you said a certain amount don't.
The hallmark is fever. Over 90% have a fever. I can't quote an exact percentage, but I believe almost everybody has a fever.
And our case definition, what we use to try to throw a red flag up for ourselves, has sort of been scaled back to be a subjective fever with other symptoms that are consistent with Ebola, along with travel. And so it's not just the symptoms that we're looking at, but also the travel history right now, because we do not have endemic spread of Ebola here locally. And so we try to balance all that and look for that. And if there were ever a case like that, it certainly would be challenging. But I think that's the case for any sort of healthcare system as it relates to diagnosing someone. And we saw that in getting.
You also said that healthcare people call a person or come and see him twice. Say he's got diarrhea, but doesn't have a fever. Would they run a test on him to see if the Ebola virus is present?
So the health department, if we are monitoring travelers, they will be arriving initially known to be asymptomatic or without symptoms. And our procedure, as we establish that contact, as we follow up with them, if we do in-person visits to check up on them, to have them take a temperature and show us, it will begin with a phone call first to see if they're symptomatic. And that will happen before we leave the health department or when we're on site before we actually go up to the door. So again, looking out for the safety of the nurses that are involved. If they call, if they have any suspicion that there may be a risk, they will back up, and then we will go into our case management procedure of calling 911, looking at, what we have, and getting that person isolated within the hospital.
So to address your question, to come back around to that, fever is not the only symptom we ask about. So our screening tool screens for all of the symptoms. If you show up with muscle aches and tell me you've just been in Liberia, we are going to treat you just like you told me you had a fever. Okay, so that, I understand the concern, and I had the same question in my mind, but that's why we asked, do you have a fever? Have you been vomiting? Do you have diarrhea? Do you have muscle aches? Do you feel unwell? And if you have any symptom and you have a travel history that's concerned, you'll be isolated and tested to confirm. Yes, ma'am.
I think we would agree that these screening mechanisms wouldn't pick up another patient like Thomas Duncan. But from what you said and from what I've read, but I had a comment on the issue about this being found on surfaces. And there's been reports out, fairly recent reports, that this can last for many days on surfaces, especially cooler temperatures. And in light of the fact that we really can't know everything about it, I'm also concerned that the CDC, particularly Thomas Frieden, put out last week that he's so sure of what we know, that there can be no problem here. He said we've been dealing with this for decades and we know it. And I would point out and then ask you a question. We've had more than 4 times as many cases in this epidemic as all the previous 25 cases since 1976. There were only 2,400 total cases in all the previous epidemics. So in light of that, as an epidemiologist or a physician or somebody who just looks at this logically, could you not wonder if, in fact, we don't have all the data on this particular disease, on this strain, why this is different? By your own admission, it's unprecedented for an Ebola epidemic. And should not that concern then weigh on us, and we should not be overly confident that we have every single answer to how this disease is progressing, since it's not following the typical course of the previous Ebola?
Information is evolving in regards to this particular strain and this outbreak. Part of the reason why this outbreak is so severe in Western Africa is that, as I mentioned in my brief presentation, is that they initially thought this was cholera and a cholera outbreak because there were not hemorrhagic symptoms. So more patients ended up having the disease before it was ever determined it was of the Ebola virus. And then it's in a healthcare system where many of these hospitals are a room where the patients are lying side by side. They don't have single patient rooms, or if they do, they don't have the healthcare workers isolating these folks, and they have pretty severe pronounced symptoms, and the diarrhea and the vomiting is quite pronounced and quite infectious. And that is part of the reason why, I guess that's the fuel that started this fire. And then the funding for the World Health Organization has been diminished. And so unfortunately, the support to West Africa was very slow to start. And that's part of what has fueled this particular outbreak in Western Africa. But we do not have all the answers. And of course, things are evolving, and we're using our best knowledge to create a plan here in our healthcare system.
Well, I take it separate to what you said as far as that being an issue, because in fact, one of the hospitals in Liberia, I think it's the only hospital at the time, only got running water in 2005. So conditions are not particularly worse there. And to say that is because of body washing and things, which I'm sure has a big effect, but that's unchanged. And if we look at the situation and why this disease is different, I have not even seen it addressed by the DEH or the CDC, and why this particular illness is worse. So you can give a lot of reasons why it's over there, but you cannot really say that that's the only reason, and I think you just have to temper your confidence a little bit in pretending they have all the answers.
I certainly
Not
don't
you
think
particularly.
that we have all of the answers, but I think that the healthcare system has responded rapidly to find and provide answers, and this is all evolving.
I think we learn something new every day. I think, you're only in trouble when you become the learned and not the learner. So I think we want to continue to learn from other people's experience. I think one of the things that was reassuring was that the close contact that lived with Mr. Duncan for 5 days while he was known to have Ebola never developed symptoms. So, that's five or six cases. I can't speak to what's going on in Africa. I've never been to Africa. But that was reassuring to me that these were people that lived with him, including his fiancee, that were in close contact with him and his body fluids for 5 to 6 days, and they never developed any symptoms. So I think that speaks to the contagiousness, if you will, to some degree. It certainly doesn't give us all the answers.
It does to some degree, but it's true, so it's fine, but it's sort of one-sided, because you can look at the healthcare situation in Dallas, where they had personal protective equipment, and they got the disease. Now, I know you could say it's later when they have hypoviral load, et cetera, but you can't cherry pick to make your case. You have to look at every single aspect. Some are worse and inexplicable, and some are better. And I think to say we're going to poo-poo the areas we don't know, and we have no idea why Sam got that and the other nurse got that.
I hope you don't feel like we're doing that. I don't think that we're
No, actually, I think you're doing a very good job here. I'm a little irritated with the CDC's.
I can tell.
They know anything about this disease, when I think as an epidemiologist, you would have to agree there's something different about this particular epidemic.
Well, I would kind of agree with Dr. Baroco. A lot of times if you have a situation where something goes undiagnosed or misdiagnosed, you reach a certain point where enough people have it and have been spreading it that you all of a sudden have an epidemic. And with West Africa, you have some areas that are heavily populated. And you kind of, in that situation, something happened where a number of people were getting it, it was misdiagnosed, and they managed to kind of get out of control beyond what the healthcare system was able to have.
Then you have to go back and say, after the 25 previous episodes, how did you do worse on this 26th episode so that your diagnosis was so delayed?
The other 25 outbreaks all occurred within Central Africa in that area. This is the very first one in Western Africa. And, that may be part of the reason why it was misdiagnosed and they were thinking that it was something else because they had never seen anything like that before. And it was something that was caught later on versus right at the beginning, nipped in the bud. And as it relates to here, us locally, I would not presume to be overconfident. I think we learn something from every single event, either about the organism itself that's causing the disease outbreak, or about our response and our plans as it relates to responding to a particular outbreak. And that's why with most of these things, whenever there's a situation that happens, we definitely try to do our best to do an after-action report. We look at what happened, what we could have done better, what were good things that happened that were good that happened, that we can continue doing, and then what are the weaknesses that we can try to strengthen. And whether that's something that we experience here locally, or like Dr. Just was alluding to, we take a look at other situations like Dallas, and we can say, all right, what ended up going wrong there that we can kind of come back here with and say, let's focus on making sure that this doesn't happen. And I think by doing that, and by having strong partners throughout the community and different agencies and different facilities and businesses, you have a resilient community. And that is the goal, I think, for preparing and preventing anything like what's going on in Western Africa.
Georgia?
My question to you is, I've heard you and the CDC both say that the Ebola virus is not airborne. Why then the sophisticated headgear?
A lot of that is for facial protection, and then the air piece is for basically cooling. But we also wanted to take measures that went above and beyond. The same reason we use our negative pressure rooms. We have the rooms. It's an extra level of security. It's an extra level of safety. And if we have the room, we want to use it to be as safe as possible. If we have the equipment, we want to use it to be as safe as possible.
And with the profuse vomiting, and it's supposed to be projectile, this will add extra protection for the secretions that a healthcare worker could be exposed to.
Piggybacking on her question, could you provide a clear and concise difference between airborne transmission versus droplet transmission? Because I see a lot of confusion, especially online, about those two modes of transmission, and people confusing droplet transmission with airborne transmission.
Sure. So airborne typically with airborne transmission, it's usually a droplet of matter will actually aerosolize and it will be able to circulate through the environment, while a droplet though it can be sprayed, it does not actually aerosolize. And so I guess that's not very sophisticated. I didn't do a very good job defining it, but that is basically how we differentiate between droplet and airborne. And so with this virus, yes, with the bodily fluids, droplet matter can be sprayed through the environment, but then it will not aerosolize. And so the classic example for airborne transmission is tuberculosis, and that's traditionally where these precautions were defined.
And airborne transmission, of course, is a broader exposure pattern. So measles, for example, one person with measles is expected to infect 18. One person with Ebola is expected to infect potentially 2 people, which is how they spread today.
And usually 3 feet is the general rule for droplet precautions, just a general rule. If your risk of exposure with droplets is approximately 3 feet around the person.
So just to be clear on that, to help straighten this out if it's true, if you would agree, a lot of people would think that's airborne if they touch the person. They would think that when you say direct contact, it's some kind of direct contact. I touch the skin or whatever. But in fact, droplet particles are a risk, and they play into the risks in the CDC and the guidance that came out Monday. So you don't need direct contact in the sense you have to touch the patient or the person that has Ebola. If in fact you're in those 3 feet, it's spread by droplets. A lot of people would consider that airborne, but regardless, that's the reality. You could get it if in fact you were just sitting next to someone on a bus, and if they sneeze and you got those droplets on.
Yeah, I would say if you want to kind of parse that out, it's direct contact with blood or body fluids. And so if you are coughing or sneezing and you have droplets that are expelled, I mean, you can choose not to take ownership of that and all those little droplets, but they are essentially your body fluids that are coming out of your body, and then they're going. And the difference between airborne and droplet is that with droplet, the body fluids in that mist will settle out of the air within a certain distance. Gravity will take them down and they will fall down onto the environment. With airborne, some of those finer mists will dry out, and once they are dried out, they are able to kind of be taken by air currents and moved larger distances than a short radius in and around you. And that act of drying out is again something that is essentially detrimental to the Ebola virus because it cannot survive very long in a dried out state. Whereas those droplet fluids provide a small environment that's liquid for the virus to be in. And once it goes that short distance, if you're looking at coming into contact with some sort of eyes, nose, or mouth mucous membrane in order to cause an infection. But when we look at overall the outbreaks that have been managed and controlled over the last few decades, they have been done so through standard contact and droplet precautions and haven't been hampered in any way in terms of controlling them without the use of airborne precautions. So I mean, that's just a side point.
I have a question, just a comment. I want to thank you for coming and sharing this information, because a lot of stuff you get for the news is they want to make it news. But it's good to hear, what's going on here in Augusta County where we're living, and the things that you people apparently have your thumb on what's going on and how it's going on. And it's comforting, quite frankly, for me to know that we have people like you taking charge and having that in our community is a number one as far as I'm concerned.